Morning, everyone.
Good morning.
Mallory's here. Tony. Yeah.
Good morning.
Angel. Hello. Is Rachel Moses on? Yes, Rachel Crum.
Yes, Rachel Crump is here.
Okay. Angel. These get emailed to you every week.
Oh, somebody emails them to you every week,
Each.
or you email them to somebody every week.
All right, we're gonna start in 1 minute. Okay, 20 is on the test. If I cannot get to it, I will have to take those questions off and fix the test. The 3 things that are not on your study guide are the pain scales and what age to use them, how to tell your infant is in pain, and when to use what age we can start using the PCA pump. Okay, those 3 things are not on your study guide.
Can you repeat that?
The pain scales, all the different pain scales and at what age we can use them. The flat scale, the Baker Wong, the Oucher, the visual analog, and the numeric 1 to 10. And then if we don't get to 20, just ignore the stuff on the bowels that's on the study guide. Yeah, in Alexandra. Started. Is Alexandra. Hold on, I'm trying to find Alexandra's name on here. There it is.
I'm here.
I know I couldn't find you on my sheet. Crystal's here. And Corey's here. Is it Monet? I forgot who it was. Because her full name isn't on my list. Clarkson Reed. Last name Clarkson Reed. Alright, she's the only one that's missing other than the other ones that I already know about. Okay. So we are finishing chapter 16. Please make sure your cameras are on. Remember, that's how we record the attendance. You don't want to be counted as absent. So, intracranial pressure. You guys had some neurological intracranial pressure in med-surg, didn't you? Okay. You'll get more when you get to critical care, but basically it's the same in children, but there are some slight differences. So the CNS has a dynamic balance of the cerebral spinal fluid, and we talked about that with the meningitis and the hydrocephalus. It bathes the brain and spinal cord at a specific pressure. That's our intracranial pressure. When that goes up, that either the pressure by swelling of the brain or the membranes or increased amount of cerebral spinal fluid, then we have increased cranial pressure. So it can be caused by head trauma, birth trauma, the hydrocephalus, where the cerebral spinal fluid doesn't drain out of the ventricle, the
Miss
infection,
Shank,
meningitis, encephalitis, and of course, brain tumors.
Miss
Let's see.
Shank,
Yes?
Monet's here.
Oh, you're here. Okay. Let me get you marked off. There we go. Okay. So these are the signs and symptoms. Like I said, a lot of them are the same as the adult, but we've got some that are significant for kids. So we have headache, vomiting. In kids, it's usually projectile, very forceful. Visual changes, your blurred vision, your double vision, your dizziness, decreased heart rate and respirations, change in pupil reactions, sunset eyes. Do I have a picture of sunset eyes? No, I forgot to put it in here. Okay. So, sunset eyes. Oh my gosh, your book doesn't have a picture of sunset eyes? Oh, yeah, they do. Here they are. It's on page 468. Can you see the picture? How the eyes are at the bottom, the pupils are way down at the bottom? That's called sunset eyes. That is a sign that we're getting increased intracranial pressure. Change in loss of consciousness, level of consciousness. What were the ones we learned, the levels of consciousness? First one, they're conscious, awake and alert. What was the next one? Anybody got their notes from yet Tuesday? Confusion. What came after confusion? Stupor?
Lethargic.
Isn't obtunded before stupor? Obtunded, I think. Then stupor. Then coma. Yeah, obtunded is after confusion. Then it's stupor. Then it's coma. Page 466. We talked about that Tuesday. Any of your seizures. So here's specific for your infant and your early toddler. Bulging fontanelle. So that anterior fontanelle closes at what age?
12 to 18 months.
12 to 18 months. 12 to 18 months. So an 18-month-old may still have their fontanelle open, so you would see it bulging because of the pressure in the brain. And then, of course, because it's bulging and they have the not fused sutures and the two fontanelles, the posterior and anterior, they have room to swell because their skull will expand. Little children like that who their skull can expand do not have as much damage because the brain doesn't get damaged when it's swelling. The late signs, we have decreased level of consciousness. We're now going into the stupor and the coma. Depressed motor sensory responses. So now they're only going to respond to very painful stimuli. Now they start going into bradycardia, irregular respirations. Cheyne-Stokes respirations are a late sign of increased intracranial pressure. Does anybody know when else we see Cheyne-Stokes respirations? Back from fundamentals.
When they're dying.
When they're dying. Yep. So those are the two times we'll see the Cheyne-Stokes. Remember, they're like irregular, they're shallow, then they quit breathing, then they breathe a little bit fast, then they, so it's really erratic. Decerebate and decorticate posturing. Does anybody remember those? Okay. Did anybody ever play with those little wooden little dolls and you pull the string on the top of the head and the arms and legs go up? Okay. So I always remembered this by decorticate, pull the cord. You pull that cord and their arms are up. Decorticate. Okay. Decerebrate is when their arms are down straight and they're curved in. So that by their side, that's decerebrate. Does anybody know which one is worse?
Is it they celebrate because it
It's
goes to the brain?
it's the decerebrate, the one with their arms are down at their side. If they have decerebrate posturing, we've got brainstem damage. And then when they have fixed dilated pupils, you will hear nurses and doctors call them blown pupils. Oh, they have blown pupils. They're fixed and dilated, and by the time you get to that point, your brainstem has herniated. And so you're pretty much dead, except for the machines keeping you alive. So we already talked about hydrocephalus, the four ventricles, and the increased cerebral spinal fluid. So when we have that shunt infection, remember I said the shunt can get infected? So these are the signs of a shunt infection. Elevated vital signs, poor feeding, vomiting, decreased responsiveness, seizure activity, local inflammation along the shunt tract. Because remember, without that shunt draining the cerebral spinal fluid from those four ventricles in your brain, they're getting increased cranial pressure. Here is your decorticate. Pull the string, arms up, decerebrate, extended, and pronated. So head traumas in children, falls are usually number one, especially in your little ones. We got to keep those gates up for safety so they don't fall down the steps. Motor vehicle accidents, not in their car seat right. Then the older children who, are driving. Sports injuries. This is why we have to make sure they wear their equipment. A little bit about sports injuries that we didn't go over in growth and development. You should never use a used helmet. If the sport requires a helmet, you need the parents to always buy a brand new one. We don't want head traumas. Pedestrian and bicycle accidents and child abuse. We already talked about shaken baby. That'll give head trauma. But any other, throwing them down, hitting them, whatever, child abuse can cause our head trauma. So, shaken baby, they put it as a non accidental head trauma because most of the time you know what you're doing. But some parents get so frustrated that they don't think about it and they just shake the baby because the baby won't quit crying. We need to tell parents to put him in their crib and walk away and calm down and just let the kid scream, even if you have to go outside. Blows to the head, cranial impacts against the wall, furniture, or floor. Acute strokes in children. It can be ischemic or hemorrhagic types. Some of the things that might give children a stroke are going to be your hemophilias who bleed, your kids with sickle cell anemia can have strokes. And then, of course, trauma can be, another sign of stroke. But there's usually a disease that is causing the child to have a stroke. Some of the signs are the same as the adult, just the causes are different because we're not having a stroke because our arteries are clogged or narrowed. The atheral and arteriosclerosis, kids don't have strokes because of that. They have strokes for other reasons. So, any child with any neurological disorder is going to be level consciousness, vital signs, assess the head, face, and neck, cranial nerves, all 12 cranial nerves, motor function, your reflexes, sensory function, and the increased intracranial pressure symptoms. The nerves observes a child for neurological disorders. What is the earliest indication of improvement or deterioration of neurological status? Which one would you pick?
B.
B, level of consciousness. Okay, why is this one in here? That's in a total different chapter. No, it's not. Wait. Yeah, that's chapter 17. Okay. All right, and there's what we went over on Tuesday. Consciousness, confusion, obtunded, stupor, and coma. So this is the pediatric Glasgow coma scale, because remember, we can't ask the infant, do you know your name, where you are, you know, what month it is, those kinds of things. So we have to change it related to children. So your eye opening and your best motor response are pretty much the same. But when you get into the auditory and verbal stimulus, you have less than 2 years and greater than 2 years. So for the less than 2 years, are they oriented? Do they look around? Do they notice who mom is? Can they say, oh, that's mom or da? Um, do they have no words? Do they have a trach tube in? Are they using inappropriate words when they already know words? Oh, these are great. That's greater than 2. That's greater than 2. Less than 2 is smiles and listens and follows. So, if mom's voice, they follow it and look towards it. They're crying, but you can console them. 3, they get inappropriate persistent cries. So this one's the less than 2. 2, they get if they're agitated and restless. If they don't respond at all, they get a 1. And if they have a tracheal tube in, you give them a T. Because they're not going to be able to cry with a tracheal tube in. Okay?
But they do try.
So closed head injuries, they're non-penetrating. It's when you just get a blow to your head and you either get swelling, bleeding, bruising. Okay, so the 2 things that I did not put in this PowerPoint that I want to add are the Rye syndrome and encephalitis. So encephalitis is the infection in the brain or the meninges around the brain that cause the swelling. Rye syndrome, we talked about, the most common cause was aspirin with a viral illness. The symptoms of Rye syndrome: severe and continual vomiting, changes in mental status, lethargy, irritability, confusion, and hyperreflexia. Okay, so chapter 17 is perception disorder of eyes and ears. We are not going to go through all of them. We're going to go through the main ones. So remember that the newborn does not have binocular vision. They can't get both eyes to focus on the object at the same time. And a newborn has 2100 vision, or 120. Which way do you put first? 2040. Yep.
2040.
2100 vision. They can only see right smack in front of them. So then it gradually gets better. By the age of 5, they should be at 20/20 vision. By 3 to 7 months, they should be able to focus both eyes on the object. Hearing is intact at birth. All newborns get a hearing test. The reason why children get so many middle ear infections is when the children are born, their eustachian tubes are straight across from their nose. When they get any kind of infection or cold, that the infection goes right to their ears, straight across. Around the age of 5, our eustachian tubes start to slant downwards. Hold on. Yes, Brenda?
Megan, what about it?
All right. So that is why we get ear infections. Congenital disorders. Babies can actually be born with cataracts. There's a disorder where they're born with cataracts. So, of course, they have to have a new lens. They can also have infantile glaucoma. Does anybody remember what what causes glaucoma? Why we have the increased eye pressure? The vitreous humor, that, the fluid in the eye that keeps the eye moist, is supposed to be able to drain and circle around. Well, for some reason, the connections or the little ducts are closed. So that vitreous humor fluid can't get out, and it just builds up in the eye. So if you have infantile glaucoma, there was something when the baby was, developing, that those ducts did not form or open. Retinopathy of the premature baby, because again, they're not fully developed. Some just genetic disorders, and then some of them are just related to family history. Kids with Down syndrome have a lot of ear problems. So the visual acuity test, remember, most of the time it's the Snellen chart. It's either that E that you have to say which way the E's facing, letters, or it's pictures. For the audiometry one, you can't put in the hearing thing and then tell them to push the button when they hear a beep. So they have little toys in the corner of the room where they're doing the testing, the soundproof little room, and the toys will clap or do something. And if the child turns towards that noise, then they count it, and they make the clapping loud and then soft, and the child has to turn towards the sound. Tympanometry, that's where they put that little disc or thing in your ear, plug in your ear, and then they turn on the pressure and it tells how much the eardrum is moving. And then, of course, using an otoscope. When we are doing that physical exam, we need to do the 6 cardinal points that you learned about, where you need to make them look up, down, over, down, and down. Those are the 6 cardinal points of eye movement. It looks like a star. Pupillary light response. What is accommodation? PERRLA, when you do your physical assessment.
The pupils are equal, reactive to light, and accommodation, right?
Okay, so how do you check the accommodation? Do that again, Tristal.
With the pen light, like,
Okay, but with the pen light, what you're doing is it's out here. As you bring it in and they focus on that pen, their pupil is supposed to change size as you bring that pen in. You don't do it at their nose. If you do it at their nose, they're just going to look cross-eyed. In front of each eye, bring that pen forward and see if the pupil changes size as you bring that pen into the eye. That is accommodation. The red reflex you have and the corneal light reflex, you can only see those by using the ophthalmoscope. We don't usually use it. The doctor does. Okay. Weber and Rhine, I'm not going to go over now. We learned that before. Okay. So, one of the medical treatments we do for eye problems is warm compresses, corrective lenses, patching the good eye to make the bad eye stronger, eye muscle surgery. Ears, we use pressure equalizing tubes, PE. So, the surgery is called a myringotomy. No, a tympanostomy with myringotomy tubes. They are pressure equalizing tubes. So when somebody has their kid says they have tubes in their ears, that's what they're talking about. Because of that eustachian tube, if kids have allergies or sinus problems, something like that, or like Down syndrome, they can't get the air in. So it fills up with air, you get that fullness in your air, or you get fluid in there, and then that is a perfect breeding ground for bacteria to grow for an ear infection, or they can't hear because of all the fluid or air clogging in their ears. So then we put in the ear tubes. Antibiotics, antihistamines, and analgesics are what we use for conjunctivitis, otitis media, either externa or media. Retinopathy of prematurity can also be because of low birth weight, early gestational age, which is, of course, premature, sepsis in the newborn, high light intensity. So this is why, if they are under a Billy light, because they have a high bilirubin, that ultraviolet light, we have to cover their eyes because we will cause retinopathy because of the high light intensity of the ultraviolet light for the hyperbilirubinemia. Hypothermia can cause retinopathy. Hypoxia. What is the definition of hypoxia?
Low oxygen.
Low oxygen. And then duration and concentration of supplemental oxygen. In newborns, when you use a high or long concentration of oxygen, it actually damages the eyes.
That's crazy.
These are all the other things that will cause vision problems. So conjunctivitis, that is one of the most common things that we're going to see in kids' eyes. It can be bacterial, viral, or allergic. So when it's bacterial, we have red inflamed conjunctiva. We have purulent or mucoid drainage. They itch or burn or mild pain. Sometimes our eyelids swelling. You have to use antibiotics, drops, or ointment. Okay, it won't go away on its own. The other thing is, remember how I told you that I washed my kids' hair with the lice shampoo as soon as the school sent a note home, and my kids never had lice? If your kids have conjunctivitis, put the eye drops in both eyes right off the bat. Because if you don't, you're going to clear up this one, and then this one's going to get it, and then you have to do the drops again. They cannot go to school for the first 24 hours of antibiotics for conjunctivitis because it spreads so easily. So if you don't want to take more days off of work, just for the child's sake, the parent's sake, your sake.
Fast food to Arnold undercover in a gym.
What? Oh,
My mute came off on accident. I apologize.
okay. Angel, Monet, and Mariah, I don't have your cameras on.
If I
Viral.
turn my camera on, I can't hear you. It will freeze. That's why I keep it off so I can actually pay attention. But I'm here.
Okay. Just once in a while say, hey, I'm here. Okay.
I'm here. Mine's pointed to the ceiling. I've got a bunch of kids that run around without clothes on, so there's going to be pointed to the ceiling, but I'm here.
All right. Viral, it's going to be a watery or mucoid drainage. Sometimes they have photophobia and increased tearing, might have large lymph nodes. They usually have eyelid edema. And then again, if it's caused by herpes, we want antiviral, antiherpetic medicines. Allergic, it's water or stringy, they're itchy, and we use antihistamine drops. So this is bacterial conjunctivitis. What's the common name for conjunctivitis?
Pink eye?
Eye. Very
Pink
good. Pink eye. I'm not going to go through these. You should have learned them in the adult, but I'm not going to test you on those. Well, I am going to go over this last one. Nasal-chromial duct stenosis. These kids are born with their tear ducts blocked. They get infected, they can't cry, so then their eyes will dry out. So they actually have to do surgery and open up those tear ducts in these babies. We talked about strabismus because we said it's normal in the newborn. If it's, not treated, or if it stays, then we have to make sure that we patch the good eye. If that doesn't work, then we have to do surgery. So, how we know a child is having visual problems? The infant will not fix on the rattle or follow it if you shake it. They don't make eye contact with you when you have them in front of you. They're unaffected by bright light, and they don't imitate facial expressions. Then we're going to worry that maybe they have a vision problem. As the child gets older, they rub, shut, and cover their eyes, squint and blink frequently, hold objects close or sit close to the TV, bump into objects, or tilt their head or thrust forward to see. So most of the time it gets to be around kindergarten when we start noticing these issues. Unless it's like they're born with it, like, the blindness, the glaucoma, the cataracts, or strabismus staying longer than it should, then we usually start noting this around the kindergarten age. Otitis media. Otitis media is the inner ear, back behind the tympanic membrane. Otitis media infusion is it's not only infected, we have fluid in the ear. Otitis externa is the outside of the ear. Here's your pinnacle. Another name for otitis externa, does anybody know? Swimmer's ear.
Yeah.
So it's the inside of the ear, but it's on the outside of the tympanic membrane, or it's around the edge here. When they call it swimmer's ear, because of the constant exposure to water is what causes it. And then you do need antibiotics drops. So, eustachian tube dysfunction, that is your kids with Down syndrome. Even after the age of 5, they have eustachian tube dysfunction. Recurrent upper respiratory infections that keep going straight across into the ears. Daycare attendance, because we just keep passing things from person to person to person. Chronic episodes of ear infections, and smoking in the household can cause ear infections. So when the child has a ear infection, you want to know when it started, do they have a fever, nasal congestion, eye or ear pain, rubbing, pulling the ear, headache, lethargy, and behavioral changes. So one of the signs of your infant and toddler that they have an ear infection, because they don't say, oh, my ear hurts, is that they're rubbing and tugging at their ear. That's a sign that they have an ear infection. The other one is behavioral changes. They're more irritable. They cry when you lay them down flat because then the pressure, if they have fluid, hurts more. So a lot of kids do not have a fever with their ear infections. So you have to look at other things to find out that, oh, my child has an ear infection, I need to take them to the doctors, okay? So we need to explain these symptoms to parents so they know when they should bring their child in. The more recurrent ear infections, the more episodes of fluid in the ear, then we're going to have a speech language delay. Because when you're deaf, you cannot hear yourself. This is what the second one is, the one where the ear is infected and it has fluid in it. The one on the right is the normal one. So hearing loss we can lose our hearing in one ear, both ears. Language development is dependent on ability to hear. It can be conductive, sensorineural, and mixed. They can be born that way or it can be acquired through infection. Woo! I need a quick break. I'll be right back in 10 minutes.
I didn't read the.
Everybody back?
Yes, I'm here.
I need cameras on, people. Oh, there's one thing I want to tell you that we noticed with our Sylvania lab. Your growth and development is still in your classroom, but it's also in your lab. So I had my lab students upload it in both the lab and in the classroom because it's still worth 3% of your grade in the classroom. And Christy Bowling from North Canton, who does the Bright Space, has been on vacation all week, so I haven't asked her about it. What I think they want to do is they want to take that 3% out of the classroom and then just make it a lab paper. But they haven't done it yet. And so I don't want to screw everybody's grade up. Okay? So when you get your growth and development sheet done, if you don't already have it done, make sure you put it in both places. It's under week 4 in Brightspace. And then I forgot where it was in lab. But upload it in both places, please, till we can figure out what's going on. So we are in respiratory. So in OB, you should have learned that newborns are obligatory nose breathers until 1 month of age. They cannot breathe through their mouth. So if an infant gets a cold before 1 month of age, we have to make sure that we're using that bulb syringe, normal saline, and keeping that nose opened. They do produce very little mucus in the infant. It's when they get to be toddlers that you start seeing the mucus increase. But infants are still more susceptible to infection because their immune system is not developed. And then their sinuses are smaller, narrower, and are not developed. So if they do get a cold at a young age, their sinuses are going to clog up too, which adds to it going to their ears, giving them ear infection and respiratory. So a lot of times what happens is they start with the cold and it moves down into their lungs. Newborns have small nasal passages and they're prone to obstruction. They have an increased risk of airway obstruction because their tongue is larger than their throat as they grow into it. And then I think we talked about this before, where their tonsils and adenoids are large and they have to like grow into them. So then if they get an infection, it's even worse and it can close off their airway. This is just a picture of the difference in the adult size of the airway and the child size. So if they have swelling, it closes off a whole lot quicker than the adult. When a child is having difficulty, they act anxious and restless, pallor, cyanosis. Dehydration can be a problem with respiratory problems. Severe, you get the clubbing of the fingers like you do with emphysema. Of course, our breath sounds, our adventitious signs, our wheezing, our snoring, our crackling, rate and depth of respirations, respiratory effort, nasal and oral cavity, cough and other airway nodules, and stridor. When kids have narrowed airways, they do what we call a stridor, and it sounds like this. Okay? So that is what we listen for. Now, I have it on here. Do I have mine? Okay, I don't. Okay, let me go through that. All right. So when children have respiratory distress, some of the signs are, we call it accessory muscles being used, and then they have nasal flaring. You can actually see their nostrils flare, okay? With accessory muscles, they're using muscles that you don't normally use to breathe. When it pulls in here at the top of the throat and it caves in when they're breathing, it's called suprasternal. Then you will see them breathing in in between their ribs. It'll pull in when they take a breath. Okay? Those are called, this is suprasternal retraction. Intercostal retractions. And then they pull in down here where that xiphoid process is, suprasternal retraction. So you'll see their nose flaying, and then they have where it sucks in all these spaces called retractions. Suprasternal, intercostal, substernal retractions. Remember, your wheezing is that high-pitched sing-songy sound. Rails are we're not allowed to call them rails anymore. I should have took that off. They're crackles. They sound like the Rice Krispies or the crinkling of paper.
Or hair dryer.
And then we have that snoring, gurgling noise. These are the same as we use in adults. So for treating of respiratory, of course, we're going to use oxygen, high humidity, suctioning, and chest physiotherapy and postural drainage, chest PT and PD. So in children and even some adults with like cystic fibrosis, instead of cupping your hands or using that little rubber suction cup thing to clap on the back to do the chest PT, and the postural drainage, remember, is how we angle them to drain the different lobes, whether they're on their side, their back, their front. We have a vest now where you put on the vest, you hook up the machine, and it actually does the chest PT everywhere, all the lobes at the same time. Other ones will do the front, then it'll do the back, but it is a lot easier because, as you can see, he's sitting up playing while he's getting his chest physiotherapy.
They make funny sounds when they do it.
Saline gargles and lavage, mucolytic agents, chest tubes when it's severe, and a bronchoscopy or when they go down and look into the lungs. So prematurity gives a high risk for respiratory disorders. Their lungs are not developed, and so they have respiratory problems. Other chronic illnesses that can cause a lot of respiratory problems are kids who are diabetics, sickle cell anemia, cystic fibrosis, any of your congenital heart disease, and any kind of chronic lung disease. Cerebral palsy will sometimes affect their lungs because they are kind of hunched over, and so they can't get air expanded down into their lungs. Exposure to cigarette smoke, immune deficiency to problems, crowded living conditions, low socioeconomic status, that could be your TB. And then, of course, daycare, because when in daycare, they're just constantly exposed to germs.
Say hello to everybody.
TB, kids who have HIV infection. If the parents have been incarcerated, or if the child is in an institution, like in our area, it's Sunshine Children's Home. Positive or recent history of latent TB, immigration or travel, So those are the kids that are risk for tuberculosis. Pneumothorax, chest trauma, intubation, mechanical ventilation, history of chronic lung disease such as cystic fibrosis. What is a pneumothorax?
Flapped lung.
Why is the lung flat?
Is that air in the pleural space?
Yes. So there's a hole and you get air in the pleural space, so now it won't let the lungs expand. If it's a pneumothorax, it's usually air. A hemothorax, it's blood. So we talked about tachypnea, breathing fast, the 3 different retractions, nasal flaring, and then sometimes the little ones will grunt like that to try to breathe. Okay. So the most common infection disorders you're going to see, the common cold or sinusitis, the flu, and we have influenza A, B, C, D, and then whatever they decide to name the flu that year. Anybody know what they named it this year? I never heard.
I never paid any attention.
I think it was N.
Oh, okay. Then pharyngitis, sore throat. Tonsillitis, infection in your tonsils. Laryngitis, your larynx, so you lose your voice. There are 3 croup symptoms we will go through. There is laryngeal bronchiolitis, epiglottitis, and I think, oh my God, what's the third one? Laryngeal bronchiolitis is the one that is most common when you hear someone say croup. That's usually what they are referring to. Might be bronchiolitis. That might be the third type of croup. Respiratory sinolytic virus, RSV. We should all know about that because of the news and everything else. RSV in an adult is a really bad cold. In a little one, it is severe. And infants can die from RSV. Pneumonia, and then, of course, bronchitis. Bronchiolitis is one of the things that is caused by RSV. Runny nose, sometimes profuse, sore throat, pharyngitis, low-grade fever, cough 1 to 3 days into the illness, and then they start having a lot of wheezing, coughing, trouble breathing, and of course, the baby has trouble feeding because they're sucking on a bottle. They can't suck and breathe at the same time. Croup is the laryngeal tracheal bronchitis, the most common one. It's rare after the age of 6 years old. Kids don't usually get croup after the age of 6. Their larynx, trachea, and bronchi are all inflamed, and they have stridor and that seal-like barky cough. Hoot, hoot, hoot. That's what it sounds like. If you go to the zoo and listen to the seals, it's a seal-like barky cough. It seems to worsen at night. steroids, cool mist, humidifier, steamy bathroom, sitting up to breathe easier, and if it's very severe and the steroids don't help, racemic epinephrine aerosol treatment. So this is the one where the kids get it like in the winter, spring, early spring, and the parents are panicking and they take the kid to the ER and it's kind of a cool night out. And by the time they get to the ER, the kid is fine. That is because of the cool air that they breathe in. It helps decrease the inflammation and then they can breathe. But they still go ahead and put them on steroids because it's just going to happen again. Epiglottitis, which is another form of croup, is a medical emergency. Now, remember how I told you that our Haemophilus influenza meningitis cases went way down because we changed the way we give the Hib vaccine? We don't see epiglottitis as often anymore either, because again, it's Haemophilus influenza. By giving more frequently in a younger age of that Hib vaccine, it is much better. The epiglottis gets swollen and cherry red and will occlude the airway. They have a high fever and they drool. Because their throat is so swollen, they can't swallow, so they drool. They are in respiratory distress. They tripod sit. They squat down on the floor and put their hands in front of them and lean forward. Tripod sitting. There is no cough. They don't cough when they have this. Never leave the child unattended and prepare for emergency trach or intubation. The biggest thing you have to know about epiglottitis is if you suspect it in that child, do not let anyone look in that child's throat until the doctor is right there and is ready to intubate. The minute someone opens their throat to look in their throat or to use a tongue blade, their airway will close. That's why it's a medical emergency. They need antibiotics right away, and we have to either intubate, or if it already closed off, we have to do an emergency trach so the child can breathe. This is the picture. A is normal, B is epiglottitis. So as you can see, their whole airway is going to close off. Chronic disorders are your allergic rhinitis, your asthma, bronchopulmonary dysplasia. Most of the time, that is because the baby was either premature or they were on the vent because they had meconium in their lungs, and then cystic fibrosis, and then apneic spells. So with your epiglottitis, like I said, don't put them in supine. Make sure they're sitting up. Do not look in the throat. Do not leave them unattended. 100% oxygen, and then we either intubate or trach. Asthma is the same in the adults. When a child has asthma, though, it tends to be worse because their airway is small. So they have a lot of mucus production. Their airway swells up and it's already narrow. And so airway obstruction, either partially or complete, is what happens in these kids when they have asthma at a young age. So there can be triggers or allergens that cause it. Cigarette smoke can be, a cause. Any kind of toxic fumes. And then whatever the child is allergic to. They're going to have tachypnea, breathe fast, increased work of breathing using their accessory muscles, coughing, mucus, and then that historic wheeze that you hear as the airways are narrowed and the air is trying to squeeze through those airways. So we have to classify the asthma based on severity. Okay. Rescue medicines are your short-acting bronchial dilators. What is your short-acting bronchial dilator?
Is that albuterol?
Albuterol. So we either have the handheld albuterol or the nebulizer albuterol. But that is for rescue when they are in severe distress or they go into an asthma attack. Your inhaled corticosteroids and long-acting bronchial dilators, ipratropium. Is that a long-acting?
No, Duaneb is.
Duoneb has albuterol and
Bipotropion. Yeah.
How do you say it?
It's big U, so bupropion.
How do you say it? Ipratropium? Is that what you said?
I think it's
I never can pronounce it. I know what it looks like.
I don't know.
Yeah.
I have some.
And then your corticosteroids are like your Advair.
Ipratropium, bromide, butyryl sulfate.
Say it again.
Ipratropium,
Ipratropium.
bromide, butyryl sulfate.
Okay, thank you very much. I have trouble pronouncing that one. Your leukotriene modifier. Does anybody know the name of that med?
Singular?
Singular.
Hey.
Singular is a leukotriene modifier. So those are ones we use every day to prevent them from having an asthma attack. And then the albuterol is the rescue when they're actually having an asthma attack. Cystic fibrosis is an autosomal recessive disease. So both parents can be carriers and not actually have the disease. And then every time they have a child, they have a 1 in 4 chance of having a child with actual disease. So cystic fibrosis is a disease that affects the exocrine glands. It affects the lungs, the pancreas, the sweat glands, and the GI tract. All of these produce a very thick mucus, okay? Especially when it's in the airway, they can't breathe, and then they get a lot of respiratory infections when they have cystic fibrosis. With the pancreas, it doesn't secrete pancreatic enzymes, and the child has to take pancreatic enzymes as a pill or liquid. We have hypersecretion of our gastric acids in cystic fibrosis. Their sweat glands, their sweat is salty. and then their lungs clog up. So we have to make sure their lungs don't clog up with all this mucus. They get aerosol treatments from the nebulizer, constantly, like 4 times a day. They have to have chest PT 3-4 times a day. They'll give them Dornase alpha, which is a pulmonary enzyme. They give them inhaled antibiotics if they're having an exacerbation and they are really clogged up. In addition to the pancreatic enzyme supplements that we give them before each meal, before each snack, they have to have vitamin A, D, E, and K supplements. A, D, E, and K are what kind of vitamins?
Fat soluble.
Fat soluble. And then they have to have a well-balanced, high-calorie, high-protein diet. Because of the loss of those pancreatic enzymes, the increased mucus, and the hypersecretion of gastric acid. The test for cystic fibrosis is called a sweat test. And what they are doing is they put a little petri dish and tape it on, and they catch the sweat of the child, and then they analyze it for chlorine and sodium. Trying to see if it's more than just the sodium and the chlorine that they check for in the sweat test. Nope, just the sodium and chloride in the sweat test. It's called the sweat chloride test. So these kids now with cystic fibrosis can live well into their 50s. We're seeing some nowadays living into their 60s. In the old days, people lived to be 20s. That was it. Our medical advances have made so much advancement that someone with cystic fibrosis can live a long life. In addition to that thick mucus, they have air trapping. Their pulmonary parasemia. What is it?
Pulmonary parasema.
Airway obstruction. They have trouble clearing their airway, respiratory distress, impaired gas exchange, barrel chest. Where else in respiratory problems do we see the barrel chest and the clubbing of the fingers?
COPD.
Emphysema. They are when the airway is really bad and you're not getting that oxygen and you have to put so much effort into breathing, we get that barrel chest. They will have recurrent pneumonia. You find it?
It's the essential part. So basically, when they have pulmonary parasema is eventually destroyed, that is the oli and the alveolar ducts collapsing.
In the alveoli?
Yep.
Oh.
They don't open properly. So this is the correct, like when everything's going good and the alveoli and stuff is opening, well, then it stops opening and that's when that happens.
Oh.
That's why it says it'll eventually be destroyed. So the alveoli are eventually destroyed.
So the pulmonary parasemia is what is around in the alveoli? that lets the alveoli open and close like a balloon to get the oxygen CO2 exchange, that gets destroyed, and that's why the alveoli eventually are like a balloon that you blew up and blew up and blew up, and then it's all out of shape. That's what your alveoli look like. I never can say this one either.
Hemophilia or phytisis.
Phytisis. Hemoptysis. Does anybody know what that is? Coughing up blood. Your TB patients are going to cough up blood. They have that hemoptysis. Cystic fibrosis can lead to pneumothorax, chronic sinusitis, and nasal polyps. When it affects the GI tract, because we have that decreased chlorine and water in our body, because it's coming out in our sweat, we have dehydration of the intestinal tract. And then it goes into the bile ducts, causing the bile to be thicker. Reduced pancreatic bicarbonate secretion, hypersecretion of gastric acid, insufficiency of your pancreatic enzymes, amylase, lipase, pancrease. All of those digest or help us digest different materials. Amylase is proteins, lipase is your lipids. I forgot what pancrease helps break down. The pancreas secretes a thick mucus. Babies born with cystic fibrosis will get a meconium ileus. What do I mean by meconium ileus? What happens when that newborn has a meconium ileus?
Is it when they don't poop? Constipated?
Exactly. So the bowels are not moving. We don't have that nice peristalsis of the bowels. That's what the ileus is. It's like the bowels just are like this and stuck. And so then we don't have that first meconium stool. That's one of the signs that, too, when the infant is born, that might say this kid has cystic fibrosis. Sludging of the intestinal contents leads to fecal impact, bowel obstruction, rectal prolapse. They can have cirrhosis of the liver and the esophageal, splenomegaly, gallstones, acid reflux, inadequate protein absorption, inadequate absorption of iron, vitamin A, D, E, and K, and then the baby is a failure to thrive. So if the parents don't know they're carriers, so we're not suspecting that the child might have it, the baby's going to be failure to thrive, and then we're going to realize something's wrong, do testing, and find out the child has cystic fibrosis. There's the sweat chloride test. And then, of course, if we check their pulse ox, it's going to be low, especially when they're having exacerbation. So their lungs are just full of mucus. They go in the hospital and we call it a clean out. They give a lot of IV fluids, intensive suctioning aerosols, and they try to get rid of the mucus that is clogging the child's body. alternatives to traditional mechanical ventilation so that we don't have to put them on a vent. High frequency oscillators, nitrous oxide inhalation, perfluorocarbon liquid. It acts like surfactant because the preemie, if they're born early, they don't have that surfactant produced in their lungs. Surfactant is what keeps our alveoli open and our lungs open. Then there is extracorporeal membrane oxygenation called ECMO, and they can do that also for these kids so that we don't have to put them on the vent. Apnea. Apnea, of course, is the absence of breathing. Absence, pnea, breathing. If the child stops breathing for longer than 20 seconds, we say they have apnea. It can be central, unrelated to cause or due to illness. They just are not developed enough and they have apneic spells. Apneic spells have nothing to do with SIDS. Okay? They're totally separate. Sudden infant death syndrome, they say, is a retention of CO2. Apnea, you just aren't breathing. Premature babies, that are anemic, cardiac or respiratory disorders they're born with, or neurological disorders. All these kids can be at risk to have apneic spells. Caffeine and theophylline may be ordered, and then an apnea monitor. Usually the infant outgrows it. They don't continue to have this all their life. This is an apnea monitor. As you can see, it's attached on a soft band and it's velcroed on. So as the child moves around, of course, those things move, and sometimes it will alarm because they're not in the right place, not that the child's not breathing. Okay? When you are teaching parents about this apnea monitor, you can go without sleep and answer those false alarms for a year or two till your kid outgrows this. I was doing home care for a child, and she didn't get a nurse every single night, okay? But I would go there at night, and I would be up all night watching this baby. He had a trach, and he was on the apnea monitor. Mom did not feel like listening to the false alarms, and so she did not put it on him that night. He pulled his trach out and was dead when she went in there that morning. Your child's life is more important than your sleep. Okay? Parents have to use that apnea monitor. Yes, it's a pain to have all those false alarms, but your child's alive. Okay, the one thing I want to go over is the tonsillectomy, because remember we talked about it blocking their airway because their tonsils are huge. So after they get their tonsils out, now we no longer just routinely take tonsils out. There's a big thing they follow now. You have to have so many infections every year, untreated with antibiotics or just the normal dose. But when they have a tonsillectomy, we have a high risk of hemorrhage. Plus, the child doesn't like to swallow because it hurts. We have to place the child in side lying or prone position. Discourage coughing. If they cough, they can make themselves hemorrhage. We need to avoid citrus juices that are going to burn the throat. And then no brown or red liquids. If they drink brown or red liquids, we can't tell if they're going to hemorrhage or not. We want to be able to tell they're hemorrhaging. We use an ice collar. You can just use one of those pre-packaged ice things and wrap it around. Sometimes we just crush ice, put it in a baggie, put it in a glove, and put that on their neck. That helps the swelling so the child will drink more. And then analgesics, Tylenol or Tylenol with codeine is what we use. The hardest part to get across to this child is the more they drink, the less pain they have, and the faster it heals. You have to keep the throat moist. Using things like, popsicles, ices, slushes help because they're cold and they numb the throat. If you see the child swallowing a lot, it may be an indication that they're bleeding, that they're hemorrhaging. And then they need to turn around and go back in. This is one of those times we don't want to wait till they're in pain. We want to give them that Tylenol or Tylenol with codeine every 6 hours or every 4 hours, because these are the kids that end up coming back in the hospital because they're dehydrated, because they won't drink. Non-infectious respiratory disorders, epistaxis is your bloody nose, foreign body aspiration, respiratory distress syndrome, acute respiratory distress syndrome, and a pneumothorax because of the fact that they have a trauma or something like that. So the one I want to talk about is the foreign body aspiration. We have to make sure that kids aren't getting little tiny objects and aspirating them into their lungs. So we had a toddler, and he was probably close to 3. But anyway, he had pneumonia really bad. We got it treated, sent him home, and he came right back in with pneumonia again, really severe. So they did a bronchoscopy, and they went in there, and he had a little piece of the latex balloon stuck down in his lung.
He was chewing on a balloon?
So he aspirated a piece of balloon. Was he chewing on it? Probably. So anyway, then once they removed that little piece of balloon, we cleared up the pneumonia again, and he was fine. This is why they don't want kids to have those rubber balloons, the latex balloons, unless you are right with the child. Otherwise, what kind of balloons are you supposed to be buying?
No.
Mylar. The Mylar ones. The ones that are that silvery.
Oh, the helium balloons.
Huh?
The helium balloons?
You can put helium in a latex balloon.
Right, but usually when I think of the silvery
The
Mylar
silvery
balloons,
ones are
that
Mylar.
say happy birthday. I
Yes.
consider those the helium balloons because those are usually nothing but helium. My answer is none. Give them no balloons.
One of the other ones that I yeah, I think we went over strep throat. Yeah. Okay. So when they have chronic respiratory conditions, we have to promote self-esteem through education and support. We have to let them take control of the management of the disease, help the whole family cope, be culturally sensitive, and we need to make sure that we don't get that vulnerable child syndrome, okay? We want them to do as much as they can as a normal child when they have these chronic respiratory conditions. We're going to get through it all.
Yay. 14. Sorry.
So we will not be taking a lunch, eat while you're in class. We'll only be taking our little 10-minute breaks. And I do not care if you eat in front of me. I'd rather you eat in front of me. Because then you got to go, some of you guys got to go take your math test. The next chapter is pretty long and it's a little more complicated. Okay? We will get through that one. Whether we make it to 20, I do not know. Or we might get through half of 20. But go ahead and take 10 minutes and then we'll work on the really long chapter 19.
Miss Shank, I'm present.
You're back? Okay.
Yes.
All right,
Thank
we'll
you.
put you in.
Miss Shank, I don't know if you got my email this morning.
Oh, you're in now too. Okay.
Yeah.
Got it. Thank you.
Okay. Mm-hmm.
Well, I don't have seizures, but every now and again, if I get a flare up or I haven't taken my Lyrica, my nerves will literally shock me, and you'll see my hand go like this or my foot jerk out.
Did you actually, Lyrica actually helps with your fibromyalgia?
Mm-hmm.
Didn't do a thing. Didn't do a thing for me. I just quit taking it.
Lyrica works wonders for me. Some people, gabapentin works for them.
Gabapentin, I would have felt like I was drugged. I was on the lowest dose, and I still felt drugged.
I thought gabapentin was nothing but water. They had me on like the highest dose they could, taking it 4 times a day.
Isn't that funny? And me, the lowest dose, just I felt drugged all day long.
I looked at my husband, I'm like, I can't do this. And then if my feet get really bad for like some reason, I've got the burning and the tingling in my feet. Vicks. You put Vicks on your feet.
All right, everybody back?
Yes, I'm back.
Okay. I'm going to get started. So, chapter 9 is basically cardiovascular, the heart. So, the fetal heart rate present around post-conceptual day of 17. The heart chambers and arteries form during gestational weeks 2 through 8. And the oxygenation of the fetus happens through the placenta. The lungs are perfused with blood, but they don't perform oxygenation and ventilation in the fetus. So these are the two big things that the fetus has, so that the blood supplies the heart with blood, but we are not supplying the body with oxygen from the lungs. That comes from mom, the umbilical cord, and the placenta. The foraminal valley is an opening between the two aortas, the atria, and it just goes back and forth from the two atrias. The ductus arteriosus is a little opening or a little like stem that connects the pulmonary artery and the aorta. So blood is going back and forth there so that it's not taking the pulmonary artery blood to the lungs to pick up oxygen like we are, because they doesn't do that in the fetus. Well, what happens in sometimes is these don't close after the baby is born. So this is the fetal circulation, and there is a connection here, which is the ductus arteriosus. So the blood is going back through the aorta and the pulmonary artery. And then this is the hole between the two atria, the left and right, which is the foraminal valley. The foraminal valley usually closes pretty fast, like in a couple hours. The ductus arteriosus takes a couple days to close, but it will close within a couple days after birth. So if that does not close within a couple days, your blood that is going, deoxygenated blood is getting into the aorta and going back out to the body. Okay? Or when it now goes from the pulmonary artery into the lungs to pick up oxygen, and it comes back in through the pulmonary veins, it's oxygenated now, red, and it comes back up through the aorta. So now that oxygenated blood goes right back into the pulmonary artery and goes back into the lung. It's already got oxygen. It went back in to get more oxygen. So when we have a child that has a patent ductus arteriosus that didn't close, it's caused an increase pulmonary Increased pulmonary blood flow. Because oxygenated blood is going back to the lungs to get oxygen again when it doesn't need it, so it's increased pulmonary blood flow. So, congenital heart diseases is the largest structural anomaly we find at birth. Okay. So it is the largest one. Acquired heart problems are like through your rheumatic fever. Sickle cell anemia can cause heart disease. So we can have acquired or you're born with it congenital. Congenital heart disease is classified as decreased pulmonary blood flow, increased pulmonary blood flow, or obstructive. Okay? So the one that is decreased pulmonary blood flow, not enough of the blood is getting oxygen. The one that you need to know is the tetralogy of Fallot. Okay? It is a condition that has 4 different defects. You need to know this for the test. Pulmonic stenosis, ventral septal defect, which is a hole between your 2 ventricles, overriding aorta, so the aorta is over the right and the left ventricle, and right ventricular hypertrophy. The other ones we're not going to worry about. They're less common, and the tricuspid atresia. So the tetralogy of Fallot, here's the picture, okay? So your valve, your pulmonary valve, that is going from your right ventricle into your pulmonary artery is not letting the blood come up through. So then the blood can't get here to get to the lungs to pick up oxygen. Then you have an enlarged right ventricle. It's hypertrophied. So it's not getting the squeeze that it needs to squeeze that blood through to go to the lungs. So it's decreased pulmonary flow. Then you have the hole in between the 2 ventricles. So you're mixing the deoxygenated blood and the oxygenated blood together. The 4th one is the overriding aorta. Your aorta is supposed to be over your left ventricle because that's where the oxygenated blood then goes out to the aorta and to the body. But it sits over both the left and the right ventricle. So deoxygenated blood is going up through the aorta and out to the body, along with the oxygenated blood. So this baby is not getting a lot of oxygen to his body. Decreased pulmonary blood flow. I think I put the handout. If not, I'll get it today on the TET spells. They're called cyanotic spells or TET spells. They're called the TET because it's the first 3 letters of tetralogy of Fallot. These babies will turn blue around their hands, feet, and mouth, or maybe around their eyes, anytime they are eating, sucking on a bottle, or when they have crying episodes. So, to relieve these hypercyanotic spells, or their TET spells, you use a calm, comforting approach because you don't want the baby to be more anxious than he is. Place the infant in the knee chest position. So while you're holding them, You bring their knees up to their chest and hold them like that. An older child will just drop down on their on their haunches, and they will bend down and do a knee chest position because their body knows to do that for them to get oxygen. Then we put them on supplemental oxygen. If they are in the hospital and they have a spell, we give them morphine, IV fluids, and propanolol IV. Propanolol is a beta blocker, right?
Yes.
Propanolol is your beta blocker, and it helps the heart pump a little better. So these babies are usually born blue, and we just call them blue babies sometimes. So this cyanosis around the lips, the eyes, the hands, and the feet is not going to go away after our 5-minute APGAR. It stays. We're probably going to hear a murmur because of that blood rushing back and forth. Some, if it's not as severe, some will show only mild cyanosis, but if they start crying or eating, then they'll turn blue. The repair is done in steps. So this isn't like immediately this baby's going to get better. You have 4 defects. What one of those 4 defects do you think we can never do anything about? Which one can we not fix? Come
The
on.
enlargement of the ventricles.
Thank you. The hypertrophy or enlargement of the right ventricle. There's no way to fix that. We fix the other 3 things, but the child will always have some kind of heart condition because we can't repair that. So the increased pulmonary blood flow, when oxygenated blood is going back to the lungs to get more oxygen when it's already oxygenated, are 3 different ones. The patent ductus arteriosus, which I just did with you, atrial septal defect, which is the hole in between the 2 atriums mixing the blood, and the ventral septal defect when the blood is mixing in the ventricles. So you have this hole in between your ventricles. So in the pulmonary veins, after the blood went to the lungs, picked up oxygen, and is coming back in through the pulmonary veins, left atrium, left ventricle, and now it's supposed to go back out through the aorta to the body to oxygenate the body. That oxygenated blood is going right back into the right ventricle, back up through the pulmonary artery, and back out to the lungs. It's also taking deoxygenated blood into the right ventricle, so it's taking deoxygenated blood back out to the body. So anytime we have a mixture of oxygenated and deoxygenated blood, we have an increased pulmonary blood flow. With all 3 of these, they want to try to see if it will close on its own. Well, I gotta do that first. There again is the patent ductus arteriosus. That little area there did not close within the first couple days of birth.
Do they eventually kind of grow out of it?
Well, this one, they tried to
Yeah.
let the hole close on its own. Okay, so they will not repair any of these 3 unless they're very severe. for a while. They wait and see what happens to the child, the baby, and if it closes on its own. So they're going to frequently be seeing the cardiologist, frequently having tests to see if it will close on its own. If it does not close on its own, there's a little patch that we can do for the atrial septal defect and the ventral septal defect. And they put a patch on it to try to close the hole. If that doesn't work, then they have to go in and actually sew it up closed, which is more risk. The patent ductus arteriosus, they first try a medication. Let me see if I can remember the name of the medication. No.
Indamycin or ibuprofen.
Is that what it is? Okay. It's not in your book for some reason. I don't know why. But yeah, so they give those medications and try to see if that patent ductus arteriosus will close. If the medicine doesn't work, then they have to have open heart surgery and surgically close it. So they
Is there a
first
certain age that they kind of like, if the medicine doesn't
know
work by this
because
point?
it depends on how big the opening is, and it depends on how it affects the child. So if the child is
That's just
hurt,
really scary.
yes, it is, because you're waiting. You know, it's a waiting game. And you're like, is any day this, going to severely harm my child? But, open heart surgery is serious. So that's why they want to try to see if it will either do it on its own or do it with medication before they go in and do open heart surgery on an infant or toddler.
My uncle had heart surgery when he was 6 months old, and they say it was a hole in his heart. Is that what they meant?
That's what they
Like, is
meant.
this
So it was either a hole
okay?
between the two atrium or a hole between the two ventricles. So he had to be severe. It had to be a huge hole so that it was affecting his
Yeah,
oxygenation and he was turning blue and all that and couldn't feed because they weren't going to wait to see if that one closed on its own. At 6 months,
yeah,
it
he
was
had it at
already, nope,
6 months,
we got to close it.
My
So,
daughter
and
was
now he's
yeah,
now he's
my daughter
40.
was born
Oh,
with
sorry.
sorry. My daughter was born with tricuspid atresia. So
oh, okay.
I was hoping you go over it, but it looks like you said it's rare. So she was diagnosed when I was 20 weeks pregnant. That was when they found out that. Then she had to go 2 stages of open heart surgeries.
So she had her surgery right at newborn.
She was supposed to have it right at they life flighted her after she was born, but she was doing well. She didn't get the first surgery until she was 3 months, and then she got the other one, which they did to close the hole as well, because she had a hole and tricuspid atresia. So they have to do
Oh,
the 2 surgeries when she was 3 years, like 3 months and 3 years. Yeah.
okay. So see, the one, the atrasia, didn't clear up, took her at 3 months. Her hole, they were waiting, and they waited till she was 3 years old to close up the ventral septal defect, the hole. So that's why I said her uncle was 6 months old. Her daughter was 3 years old. It depends on how big the hole is, but they want to see if it will close up on its own before they go in and do open heart surgery on a small child. The obstructive disorders, corrotation of the aorta, is where we have this little narrow area. this will have to be done early. This surgery can't wait, okay? So, and it depends on how big this area is narrowed to what they do. If they can just go in and put a stent in there and open it, they'll do that. Otherwise, they have to actually remove that narrowed area and anastomose the two parts of the aorta back together. Aortic and pulmonary stenosis are your valves, and they have to replace those valves, or blood just keeps regurgitating. The mixed disorders are a lot rarer, okay? Transposition of the greater vesicles. Your aorta is attached to your right ventricle, and your aorta is to the right ventricle, and your pulmonary artery is attached to the left ventricle. Hopefully, this is found in utero, because if they cannot fix this in utero, do surgery in the mom's belly, this is the minute the baby's born, the baby's going for open heart surgery. The minute that baby comes out. So it's usually found on ultrasounds while mom is pregnant. They cannot survive with their vessels attached to the wrong ventricle. So, heart disorders, any other congenital malformation, they usually have more than one. Genetic syndromes, all your children with Down syndrome, ventroseptal defect is very, very common in a child with Down syndrome. Family history of heart birth defects, maternal drug and alcohol exposure, and then prematurity is another one that can cause heart problems. When we have an acquired heart disease, rheumatic fever, Kawasaki's disease, and endocarditis can all give us heart problems. Obesity in the children, diabetes. You know, when you're diagnosed as a diabetic at the age of 3, well, we know diabetes damages the hearts and the blood vessels. Just think if you're starting at the age of 3 with that. Hypertension, whether it is a kidney problem, a liver problem, or we just have hypertension in younger kids nowadays because of our diet. Chemotherapy. I'm going to tell you a really sad story of one of the instructors that was working here about a year ago. Her daughter, at the age of 8, had osteosarcoma. She had a bone tumor. They did the chemo, radiation, all that. She survived the cancer. It affected her heart. At the age of 15, she had a heart transplant. At the age of 23, her heart transplant was going bad, and she needed another heart. It went bad faster than she could get a heart, and she died at 23. So here you're so excited your child survived cancer, and then 7 years later, her heart goes out because of the chemotherapy. Connective tissue disorders, autoimmune diseases, and other endocrine, not just diabetes, can cause heart problems. Any organ transplant, whether it is your liver, your spleen, your kidneys, whatever, because when we get an organ transplant, it puts more workload on our heart. And then hyperlipidemia. Hyperlipidemia, there is a thing where an actual newborn can have hyperlipidemia. They're just the way that they were developed, they have a really high cholesterol level, and LDL or no, LDL is good. No, LDL is bad. HDL is good. A high LDL, they're just born like that, so they have hyperlipidemia. Otherwise, it's the diet. Okay, we're seeing more and more younger kids again with hyperlipidemia. Both parents have to work. Sometimes one parent has to work 2 jobs and one parent works another job because our economy is so bad. And so, what are we feeding our kids? Fast food, pre-packaged foods. So now we see hypertension and hyperlipidemia in our younger kids. Trump's not helping.
No.
Diagnostic tests are the same as what we do for adults. They're the same tests. We just do them in the kids. C-reactive protein. You guys learn about C-reactive protein? When do we usually do a C-reactive protein in an adult?
Is it when we suspect protein in the urine?
Nope. C-reactive
Inflammation.
is a blood test. Heart attack.
Okay, heart attack. Okay.
That's going to be high if they have a heart attack. Now, the SED rate, we call it, the erythrocyte sedimentation rate, when are you going to see that high? What? Inflammation. So, like people with arthritis, people with lupus, their SED rate is going to be high because of the inflammatory process of those diseases. So this is in your book. Oxygen, of course, supplemental oxygen, chest physio and postural drainage, a chest tube if we have a pneumothorax or after open heart surgery. And we put pacemakers in children, just like we do adults. Okay? If they have bradyarrhythmias, heart blocks, cardiomyopathy, anything wrong with your SA or AV node malfunctions, we will put in a pacemaker in a child. When a child is undergoing cardiac surgery, we need to make sure we assess and keep track of their temperature, their weight. Are they gaining weight back, or they're gaining too much weight because they now are going into congestive heart failure and they have fluid retention? Evaluate their extremities, peripheral edema, clubbing, peripheral pulses. If they have peripheral edema, what do you think they're going into?
Heart failure?
Heart failure. Your peripheral pulses, you're not getting circulation. Auscultate the heart. We're looking for rate, rhythm, heart sounds, murmurs, clicks, rubs. The S3, the S4s. We should only have an S1 and an S2, a lub dub. Then, if we go into heart failure, we can always get fluid in our lungs. So left-sided heart failure, you have fluid in your extremities. Right-sided No. Left-sided heart failure, fluid in the lungs. Right-sided heart failure, fluid in the extremities and stomach. So if you have fluid in your lungs from heart failure, you're going to have trouble breathing. And you might have crackles. The nurse is assessing a child for cardiac disorders and documents. The presence of clubbing of the fingers and toes is a condition that might indicate what?
D.
D, hypoxia. You know,
Hypoxia.
hypoxia, very good. So, any of these problems can lead to heart failure. Any of the acquired heart problems, or if it's a congenital heart problem. So we need to make sure that this child is getting proper oxygenation, supporting cardiac function, whether it's medications or pacemaker, adequate nutrition, and promoting rest. They get their rest periods. So we want to make sure we are treating, and do I have more on that? Let's see, that's infectious. Cardiomyopathy, Kawasaki's, okay. Dig is something that we do use in children. If I didn't already add it, I will add the handout on dig in children. So infectious endocarditis is an infection in the epithelial lining of the surface of the heart. If a child has prosthetic valves, that's one of the ways that they can get endocarditis. It's usually the valves, the chamber walls, or the septum. I've seen it mostly happen with the valves. So when you have rheumatic fever, you had a strep infection that went into rheumatic fever. When you have rheumatic fever, you get growths on your mitral valve. And then as you get older, you eventually have to have your mitral valve replaced. So on exam, when we have a endocarditis, we're gonna the low grade fever, edema if the heart failure is present along with it, petechiae or palpebral conjunctiva on the eyes, we're going to see petechiae, and the oral mucosa and on the extremities. Raw spots are splinter hemorrhages with pale centers on the sclera, palate, inside the cheeks, the buccal mucus, chest, fingers, and toes. We have Janeway lesions, painless, flat, red, blue hemorrhagic lesions on the palms of the soles or feet. Osler notes, small, tender nodules on the pads of the toes or fingers, and black lines under the fingernails, which again are splinter hemorrhages. So all of those are signs of an endocarditis infection. Here is the growth I was talking about that happen usually on the mitral valve, but it can be the tricuspid valve also. But mostly, for some reason, it's the mitral valve. So you got strep throat, group A streptococcal. You either did not get treated for it, or some people, even if you're treated for that strep throat, the toxins stay in the body and it's a delayed sequela where these growths happen on your valve. It's an autoimmune reaction to that strep infection. And then, like I said, open heart surgery and replace the valve. So with acute rheumatic fever, we classify it with modified Jones criteria. You have to have 2 majors or 1 major and 2 minors for you, that doctor, to say that yes, you have rheumatic fever. Major carditis, migratory polyarthritis, subcutaneous knowledge, erytheum marginatum, which is a red rash, and the syndrome chorea, which I don't remember. Polyarthralgia, elevated C or C-reactive protein, and then a prolonged PR interval on your EKG. And then they just have to keep an eye on you with a cardiologist to know when you have to go in and get the valve replaced. I'm going to skip that one. Kawasaki's disease. Nobody really knows why kids get Kawasaki's. At one point, they thought it was letting the baby crawl on damp carpet after you had your carpet cleaned, but they have never verified that. It's not that common, but it is yucky when they have it. High fever for 5 days, and antibiotics don't work on it. The child has chill, headache, malaise, extreme irritability. It only happens in children less than 5 years of age. It doesn't happen to older children. This is what you specifically need to know about Kawasaki's. They have what we call a strawberry tongue. Their tongue is really red, and then it's got like dimples or spots on it, like a strawberry. Okay? Then their palms and their feet turn bright red. After that, then the skin just starts peeling off, the hands and the feet, and it also dissemination in the perineum area. Vomiting, diarrhea, abdominal and joint pain. The treatment is IV immunoglobulin and aspirin. We have to give aspirin for this one. We have to give aspirin for some kids who have juvenile arthritis. Now, if my child is on aspirin and I know the risk of aspirin and a viral syndrome or viral syndrome giving Rye syndrome, I'm going to make sure this child isn't around anybody, because I don't need them getting a viral infection while they're on this aspirin and then getting Rye syndrome. And then it causes problems with the vessels. So we need to make sure that they are monitored for coronary artery disease for a good long time after they've had this. We don't give non-steroidal anti-inflammatory drugs while they're on aspirin. You don't mix the two. They may have cervical lymphadenopathy. I was trying to find the thing about the arteries. Oh, it causes inflammation in the walls of the coronary arteries. So that's another reason why we're giving the aspirin, because we don't want any blood clot. So we want to check any child for these symptoms to know if there is something going on with their heart. Orthopenia. What is orthopenia? Lee Brown. What is orthopenia? Leah Brown. Can you talk to us? No, something's wrong with your microphone.
Difficulty breathing.
Is it
It's
When?
called shortness of
shortness
breath.
of breath?
When you are laying flat. Difficulty breathing, laying flat is orthopenia. Fatigue, lethargy, vomiting. What's diaphoresis?
Like when you feel sweaty?
Sweating. Sweating is diaphoresis. Motor delays, cyanosis, and tachypnea. We need to pay attention to all those things, and then we're going to say, we got something going on with our cardiac system. Dyspnea, easy fatigability. So you're feeding the baby, and then they can't even finish eating. They're just too fatigued to finish eating. You're playing with them, and all of a sudden they just fall asleep. Growth delays or failure to thrive. This is where we're using those growth charts. That squatting or tripod sitting, any edema, dizziness, frequent pneumonia because you got fluid in your lungs, and poor feeding because they can't suck and breathe at the same time. We want to make sure we know of any family history of heart disease, congenital heart disease, sudden death in any young family members. How many times do we hear about that high school athlete that just died on the court or in the field? They had an underlying heart condition that never got picked up until they're doing those strenuous sports, and boom, they drop dead. So if it's a sudden death like that, we want to know because this baby now could have that problem, and we're going to check this child for it. Hyperlipidemia and, of course, diabetes. So, was there any problems after birth? Any other malformation or diseases at birth? Frequent infections, chromosomal abnormalities, prematurity, autoimmune disorder, medication use such as steroids. All that is important for us to be aware of so we know if this child is going to have a heart problem. If you notice any of these symptoms in a child or infant, we need to be going to do some more studies. Cyanosis, irregular heart rate, edema, clubbing of the fingers, fever, retractions or increased worth of breathing, prominence of precordial chest wall, your barrel chest, visible engorged or abdominal pulsations of that aorta. An abdominal distension can be because of the aorta, or it could just be we have fluid ascites from heart failure. Heart murmurs. Where do we listen for the heart murmurs when we are listening to our patient's heart? Where do you listen for the pulmonic valve?
Is that the 15
Second
intercostal?
intercostal space on the right. Where do we listen for the aortic? You guys don't know the five?
I thought that was
What?
the I thought that was the second intercostal on the right.
Yes. No,
The
that's on the
aorta.
left. Isn't it? No, you're right.
Oh.
No,
Right
it's
is
the
the
right.
aortic. The pulmonic is on the left side, second intercostal space. What about the tricuspid? Fourth intercostal space on the left. And the mitral valve, where am I listening for the mitral valve?
Fifth intercostal.
Fifth intercostal, or sometimes you can just say at the apex of the heart. Yes. Other times you will hear a murmur just in between pulse or heartbeats because it's the swishing of the blood if they have ventral septal or atrial septal. But if it's because of a non-functioning valve, we listen at all those places to see if there's a murmur where the valves are. Is it harsh, musical, rough, high, medium, or low pitched? And then is it more prominent when they're sitting, lying, or standing? Most of us, unless we work on the heart floor for children, even adults, all we hear is, hey, there's a murmur here. This is where I heard the murmur. Then the doctor figures out all the rest. But you have to be able to identify that there's a swishing noise, a murmur. So we need to make sure we improve oxygenation, adequate nutrition, help them cope, post-operative nursing care if they have open heart surgery, prevent infection, child and family education. So when we're teaching parents or even an older child, we want to show them pictures of the heart. What are we actually repairing? What's going to happen through the surgery? Where their child will be after surgery in the ICU? What they're going to look like, because they'll probably be on a ventilator and have a lot of tubes. They're going to have the dressing and the incision. What kind of activity can the child do after surgery? Nutritional restrictions, and what medications the child's going to be on. So, when I am giving digoxin to an adult, when do I hold it?
When the heart rate is less than 60.
Less than
Less
60.
than 60. So now my infant's normal heart rate is 100 to 120.
When it's less than 90.
So when am I going to hold the dig?
When it's less than 90.
Less than 90. Very good. Okay? Because their normal heart rate is higher than adult, we can't wait to 60 to hold the dig. We'll kill the child. So less than 90, we're going to hold the digoxin for that child. Okay? All right. Ooh, wow, we did that. I'm going to go use the restroom again, and then we'll see how far we get in chapter 20 before 1 o'clock.
It's driving me nuts because
All right, I'm back. I gotta find chapter 20. Mm-mm-mm-mm. Uh-oh.
we don't have 23 or 20. This way. There you go. All right. I don't have it uploaded. I will upload it as soon as class is done. Okay, so this is your GI disorders. Remember, the GI system includes the mouth, the esophagus, the intestines, large and small, the biliary system. It does our fluid imbalance, our stomach, our rectum. Your laboratory tests are the same as adults. So, dehydration happens more frequently in a child because they are smaller. So, the first thing we do when they are dehydrated is we try oral rehydration. Okay? Before we do the IV. Enteral, of course, is, your feeding tube. Oral hydration for the little ones are your Pedialyte. I think there's other brands out there now, but Pedialyte is the one that we usually use for oral hydration. Again, we got to make sure that they have adequate nutrition, aren't a failure to thrive, don't have any problems with absorbing certain nutrients, causing malnutrition. Enema and bowel preparations, ostomies, probiotics, and medications. So here is your oral hydration. It usually has sodium chloride and glucose in it. Oh, here we go. Infolite, Rhizolyte, Pedialyte. We do not rehydrate with undiluted fruit juices, soup, broth, tap water, or milk. Those are not going to rehydrate your child. Mild to moderate dehydration, they need 50 to 100 mLs per kilogram every 4 hours. That's how we rehydrate the child orally. Now remember, when we do that math, that is maintenance IV fluid. If your child is dehydrated, you're going to have to calculate higher than our maintenance fluid on how much of IV fluid we're going to give them. These are all the medications you can use for GI disorders. They're the same as the adult. So, prematurity, they're not cooked long enough. Their GI system is not ready to function. Okay? Family history of problems, genetic disorders, chronic illnesses, prenatal factors, infectious agents, foreign travel, immune deficiency, and chronic steroid use are all going to put the child at risk for GI disorders, along with congenital anomalies.
So vomiting and diarrhea are going to dehydrate our child a lot faster. Decreased oral intake. They're not taking enough in. A high fever will dehydrate them. And what did we talk about fevers in children? They run high fevers. Infant, toddler, even preschooler, 103, 104 is normal for them. The child that goes into diabetic ketoacidosis, and of course, burns. We lose a lot of fluid from our burns, and therefore the child dehydrates. So your acute ones that are going to go away pretty fast are dehydration, vomiting, diarrhea. If you have oral thrush in your mouth or oral lesions, we can treat it. Hypertrophic pyloric stenosis, we're going to do surgery right away. Necrotizing enterocolitis, if it doesn't go away with antibiotics, again, surgery. Intussusception, malrotation, volvus, and appendicitis. They're acute because we're going to do surgery and we're going to fix them. So they're not chronic. The first one you need to know is pyloric stenosis. So with pyloric stenosis, we have a pyloric area valve between the intestines and the stomach. When the child is born, it's thickened so that food can't go from the stomach into the small intestine. This is what causes that projectile vomiting. Because if it can't get through to the intestine, it all sits in the stomach and then forces its way back out. This is not just vomiting. This is shoot across the room. Projectile vomiting. They're constantly hungry because every time you feed them, they vomit. Where that enlarged area is, where it's thickened and not letting the food go through, you can feel a sausage-like mass in that area. Treatment, we have to do a pyloromyotomy. They actually cut the muscle of the pylorus and relieve the gastric outlet obstruction. So this is not something that you'll see right at birth because they're not eating a lot. They're not feeding, filling their stomach as much. But as the child gets, a couple months old, that's when now it becomes a problem and you're going to notice the symptoms. So they're usually maybe 3 months old, and then you start noticing that there is a problem. There's stenosis in this book. And this is the picture. The top one is where it's closed. There's the pylorus area is narrowed and the muscle is thickened. So then they just do the surgery and now the food will flow into the intestine. Intussusception is another one that we see, and they think it's because of just weakening of the linings and in the bowels, but the bowel actually telescopes in back up into itself. Okay. So when these kids have intussusception, because as you can see, it's going back up in, the child either will not have any stools because it's totally obstructed, or they'll have a partial obstruction and they have currant jelly stools. My grandmother made currant jelly stool or currant jelly. It's a globby, mucusy, red-looking stool. Okay. They have abdominal pain, vomiting, diarrhea, and lethargy. Now, most of the time, some kids will spontaneously reduce it on its own. If the child all of a sudden has a normal stool, you know that it spontaneous reduction. It did it on its own. Otherwise, we use an air enema, pneumatic air enema. We never use barium anymore. That's old school if you ever heard of that before. It's an air enema. 90% of the time, the air enema will correct it. That if that doesn't work, it didn't come down on its own, and the kid doesn't have that normal stool, they will go in and surgically pull it out. Hirschsprung's disease is another one that they're born with. The sigmoid colon has ganglionic cells that allow it to expand, then contract, and push the stool through. These kids are born with a portion of their sigmoid colon that don't have any ganglionic cells. Therefore, it stretches and stretches and stretches and doesn't then go like this and let the stool go through. So, since it can't expand to let the stool go through, the area above this area that doesn't have the ganglionic cells, all the poop just gets stuck in there. And it just gets bigger and bigger because it can't go through that area. If they're born with it, they will not pass their first meconium stool in the first 24 hours. Otherwise, if it's not that severe, they have a ribbon-like stool. It just comes out really tiny thin like a ribbon. Abdominal pain and vomiting because their stool is not moving out of the body. When these kids have surgery to remove that aganglionic portion, they do have to have a colostomy. The colostomy is temporary. Tell parents it's temporary. As soon as they grow a little bit, that they can take the two ends and anastomose them together, they will reverse the colostomy and the child will be fine. So this is the portion down here, the sigmoid colon, that does not have the cells. So it can't expand and let the stool pass. That's why this area above it will feel like a mass when you feel it, because it's full of stool that can't continue past down. So that is the portion that they remove, and then as soon as the bowel grows enough that they can anastomose it together, the child will have the colostomy. Cleft lip and palate, omphaseal gastrocehesis, and hernias and anorectal malformation are now some other anomalies we might see. Cleft lip and palate, the cleft lip is the lip, and the palate is the hole in the roof of the mouth. Okay? We can have one side of the lip, both sides of the lip. We can have the whole palate and the lip. It's just a whole bunch of different combinations. If it's just the lip, they will do the surgery usually around 6 to 8 months of age. Because they're going to have feeding difficulties because they can't make that form to suck around the nipple. So they have to have a special kind of bottle, a special nipple when they have the cleft lip and palate. Now the palate, with the hole in the palate, it allows the food to come out the nose when they are eating. So the bottle has to be where it goes past that hole in the palate, so the food isn't just going straight out the nose. When the child has a cleft palate, the hole in the roof of their mouth, they have problems with dentation. Their teeth are either not formed right or they're not going to come in right because of the hole in the palate. Then we also have problems with ear infections because everything from the mouth goes up to the nose and out to the ears. We want to correct the palate as early as possible because they're going to have a speech delay if their palate is not repaired. There are different doctors who say different things about the palate. Some doctors will wait till they're 12 months old to correct the palate. My niece, who is 35, lives in California. That doctor said it needs to be closed earlier because by a year they're making their sounds. So their speech is delayed. So hers was probably closed around 9 months of age. So I would say between 9 months and 12 months, close the palate. By 3 months, they're closing the lip. When they do the lip, we put a Logan's bow on to reduce the tension on the lip sutures. The other thing is the baby has to be always sitting up and have elbow restraints on because we don't want them laying down and rubbing the suture line. We don't want them to be able to get their hands here for the suture line. They can't suck on a bottle after surgery, so we usually feed them with a syringe. When it's a palate, again, we don't want anything in their mouth to alter the sutures up in the top of their mouth. Again, they will be in the elbow restraints and they will get fed by a syringe. Some of the things that go along with a child with cleft lip and palate might be heart defects, ear problems, skeletal deformities, genitourinary abnormalities. Now, my niece had the heart and the ear problems. But not all, this doesn't happen all the time, go along with it. There are kids that are just born with a cleft lip and palate, okay? But a lot of times they have multiple defects. So feeding difficulties, altered dentation, delayed speech, and your otitis media, your ear infections. These are all our chronic ones. Gastric reflux, peptic ulcers, constipation, encoparesis. Encoparesis is when they are so impacted that the liquid stool comes out around the impaction. That's encoparesis. Hirschsprung's disease, short bowel, inflammatory bowel, which is your Crohn's disease and your ulcerative colitis, celiac disease when you're allergic to gluten, recurrent abdominal pain, and our child with that failure to thrive. Causes of chronic constipation. In the newborn, it can be Hirschsprung's, anorectal malformation, pseudo-obstruction, endocrine problems, dietary changes, and cystic fibrosis. As the child gets a little older, it could be holding it in. They refuse to go poop in the toilet. Short segment Hirschsprung's disease, spinal cord injuries. School age, access to the bathroom, limited ability to recognize physiological cues that they have to go. They're preoccupied with playing and they don't go to the bathroom, so they hold it and get constipated. Adolescence is usually anorexia, diet, pregnancy, laxative abuse, and irritable bowel. I'm going to skip ulcerative colitis and Crohn's because you should have learned that in the adult. And for some reason, I didn't finish that PowerPoint. Okay, so let me see what else we might need out of this chapter. Appendicitis, same as the adult. So celiac disease, glutenopathy, enteropathy. What are the foods that somebody with celiac disease cannot eat? What has gluten in it?
Certain kinds of bread or anything that has wheat.
Wheat. What else?
Whole grains.
Pasta.
That's wheat. Now there's 3 grains. Wheat, barley, rye, and oats. Those all have gluten. Wheat, barley, rye, and oats. So if they have celiac disease, they cannot eat any of those foods. Tony,
Yes.
where did you get that?
Oh, her unicorn thing
Yes.
from Amazon. From
Oh
Amazon,
my
but
gosh,
they have
my
them at the Dollar
granddaughter
Tree.
would love that.
I went to the
Oh,
Dollar Tree last night and they have them at the Dollar Tree too.
okay. I'm going to get my granddaughter one. So that is celiac disease. So when you are studying for this test, the items that I put in the study guide under week 2, those are the things you're going to have to go to the back book and read about. Do not read the entire chapter. There's too much information. Go to the book and read those topics in your book that are on the study guide. Okay? If you have any questions, because we did so much today, You guys got my phone number. You have my email. If you don't understand anything, you need it explained better, please get a hold of me, okay? It's a lot of information, but I want you to pass the test. Tuesday's topic is already uploaded, and as soon as Ring Central lets me, I will upload today's. Okay? All right. Those of you who passed your math test, have a wonderful day. The rest of you have time to get to the school and take your second math test. You can do this. You've got this. Take your time. Read the questions. Okay? Have a great day.
Miss Miss Shank.
Thank you.
Bye, thank you.
Miss Shank.
Yes.
Can I talk to you after class?
Yeah. All right, everybody else, go ahead and get off.
Bye.
Rachel, go ahead and leave the meeting. Okay, what do you need, Corey?
I'm taking the math. I have a question though. Yesterday, or not yesterday, whenever we talked, whatever day that was that we did the remediation, you asked me if I wanted to take my test after the math, but I never heard anything.
Oh, yeah, Missy said you could.
Okay, I didn't hear nothing, and my mom can't watch him.
Okay, so you want me to have, what time tomorrow do you want me to tell Missy?
I can do tomorrow. I have clinical, so I can do it right after clinical.
So that's
okay.
like at 4, 3:30?
3:30, but I'll already be there. Like we go there at 12, so I don't know
Okay.
if I can take
All
it.
right, then 3:30 I'll tell Missy.
Okay.
Okay.
All right, thank you.
Bye.
We had that hailstorm last night.
Oh, did you? Where do you live? Oh, you live down south.
Yeah, Bristol. They had we had a hailstorm and it shattered my mom's windshield. So she's got to go in and get her windshield fixed, and she can't watch my son, so I'm screwed.
Thank you, baby.
All right. Bye-bye, sweetie.
Say bye-bye. Say bye-bye.
And you have rainbow fish. I have rainbow fish.
Yeah. That was like the first book I got from the library when I was young.
Know
So I
I
got it for him.
just bought another one. They now have 4 books. Yeah.
Do they? That exact book was the one that came out when I was young. Like I remember we went to science fair and I got that book. And then we were at Walmart and I was like, oh my God, I had that when I was young. So we bought it.
So mine where my kids is, my daughter had 2 of them. The first and the second one. And so that's what I read to the grandkids. And since then they came out with 2 more of them.
This was my first toy. This was my first toy, and he already broke it.
Oh no!
He has a little.
I will
He has
let
a
Missy
giant.
know, and I'll talk to you later.
All right, thank you.
Bye.
Bye-bye.